It's my pleasure to introduce Dr. Adam Small, one of our second-year current adult congenital fellows. Dr. Small did his undergrad, medical school, and residency at University of Pennsylvania, where as a resident he was in the Med-Peds program there, as well as a chief resident. This was followed by a fellowship in adult cardiology here at UCLA, where he also was a chief fellow and currently one of our adult congenital heart disease fellows. Dr. Small is going to be talking about a case presentation and an overview of our UCLA Fontan survivorship protocol for the stable outpatient.
Hi, everybody. It's a real pleasure to be up here with all these people and considered to one of their colleagues in their company. My favorite part about all of this is that my badge actually says faculty. I'd really love that to be imprinted on the brains of my bosses up here. I think that's what a cool thing. So I'm going to try to synthesize a lot of what you guys have just heard about the Fontan and go over our outpatient screening protocol. It was Benjamin Franklin, it turns out, who first said an ounce of prevention is worth a pound of cure. Benjamin Franklin also said, God heals and the doctor takes the fees. I honestly don't know what to make of that. I just wanted you guys to be aware of the scope of scholarship of American polymath Benjamin Franklin. So first I'm going to go over a case, then I'm going to go over our protocol. This is a 53-year-old guy who was born with double inlet left ventricle. He underwent bilateral Blalock-Taussig-Thomas shunts when he was a baby, then underwent an atriopulmonary Fontan. He has a history of atrial and ventricular arrhythmias. He's had ablations, and right now he has a pacemaker and a subcutaneous ICD coil. Today, he's in your outpatient clinic. He has no new complaints, but has been having ongoing exertional intolerance. On physical exam, you can see his vital signs there. He has an oxygen saturation of 93%, and it's really hard to determine his volume status. The JVP is not well seen. For those of you who see Fontan patients, you know it's not uncommon at all. He has a slightly displaced ventricular impulse, a split S1, a normal S2, and a soft systolic murmur. His cardiac medicines, he's on carvedilol, furosemide, tadalafil, and warfarin. And that's our presentation here. So the survivorship protocol is our outpatient checklist that we use to monitor these Fontan patients. And the way that I've broken it down for you is into 4 different categories. We're going to go over hemodynamics, surveillance, and optimization. We're going to go over arrhythmia and thrombosis, Fontan-associated liver disease, and finally advanced care planning. So first, hemodynamic surveillance and optimization. So this is the checklist. We get labs, we get echo every year, we get cardiopulmonary exercise testing every 3 years, advanced cardiac imaging at least once, but then as needed, hemodynamic catheterization every decade, and then we ensure that everybody has been considered for a PDE5 inhibitor. So for our patient, what did the labs show? The way these slides are arranged, many of them, is that the data themselves are on the left and then an interpretation is on the right. So our patient had anemia. He had renal dysfunction as evidenced by an elevated creatinine. He had volume overload as evidenced by an elevated BNP. His systemic ventricle had systolic dysfunction as LVEF was 30 to 35%. He had mild to moderate mitral valve regurgitation, and he had spontaneous contrast in his right atrium, which is very common in these atriopulmonary Fontans, and it suggests a prothrombotic state, the echo smoke. He had cardiopulmonary exercise testing as well. He did 7 METs on the Bruce protocol. His oxygen saturation stayed stable, and his pulmonary parameters suggested that the limitation to his exercise was not pulmonary in origin, it was rather cardiac. His overall VO2 max, which Jeanette talked about earlier, was 15.7. So the upshot of all of this, poor exercise capacity without desaturation, and his limitation is likely cardiac in origin because he had a high breathing reserve at peak exercise and his maximum respiratory rate was below 50. So where does this bring us right now in our hemodynamics? Well, he has heart failure with ventricular systolic dysfunction. He has renal dysfunction, most likely due to cardiorenal syndrome. Of course, meds are always something that we should consider. And what do we think about when we see a Fontan who has these kind of findings? Well, first, we want to make sure there's no significant atrioventricular valve regurgitation. And in his case, we already have an echocardiogram. We know that the mitral valve regurgitation was mild to moderate, so that's not the main problem. Is there Fontan or pulmonary artery obstruction? We don't really know that yet. We just know he has limited exercise capacity. Are there collateral vessels? Jamil talked about these. Veno-venous collaterals, for example, from the Fontan going to the pulmonary veins could cause desaturation with exercise and could cause your exercise tolerance to be diminished. He didn't desat with exercise. He could still have aortopulmonary collaterals that overload the heart. Does he have restrictive lung disease? Well, we have some pulmonary parameters from his cardiopulmonary exercise testing that suggest that even if he does have restrictive lung disease, that's not really his main problem. So while I haven't ruled that out per se, it's not the biggest issue. Cross it out. Arrhythmias and liver dysfunction we're going to talk about a little bit later. So now we move on to our cross-sectional imaging. And here I have one representative slice from his CT scan, and you can see that his Fontan connection is widely patent here. And you can also see that the proximal pulmonary arteries are open as well. I don't have a pointer, so I can't show those to you. But if you look next to the descending aorta, the big white dot sort of at the bottom there, you'll see these little white dots just to the left of it. And that suggests there might be some collateral vessels, and we're not sure, at least based on this one slice, where they go. So it's a thing we'll keep in our minds. So we take from this unobstructed Fontan pathway, collaterals, not sure what the origin or destination is. So now we have our catheterization data. And Jamil said, at least I'm pretty sure he said, that the catheterization laboratory is considered a laboratory for this reason. I feel like I've heard that so many times that at this point I'm not sure whether I actually hear it or hallucinate it, because I hear it most nights when I go to bed, but the catheterization laboratory is a laboratory, and so it's not uncommon to get a diagram that looks like this after a catheterization. So I'm going to walk you through it here. We have a number of different conditions, and the different conditions have different colors, so very nicely put together for us. So first, we're going to look at our Fontan pressures and right atrial pressure. So right atrial pressure is in black, and you can see that it is 12 mean. That's the line above it. And the Fontan pressure, at least in the LPA, was 11. So that's the baseline, not so bad. At one point in the study, though, he went into atrial tachyarrhythmia, and the atrial tachyarrhythmia is in red. And you can see that when he was in atrial tachyarrhythmia, the Fontan pressures go up a bit. Now we're looking at about 15 for the Fontan pressure. They also had him exercise in the cath lab, which Dr. Abelhosen spoke about as well. And there you can see the Fontan pressures go way up with exercise, up into the 20s. So now we're really looking at a problem here in elevated Fontan pressures with exercise, which could contribute to his exercise intolerance for sure. Now we'll look at the end diastolic pressures. The end diastolic pressure at baseline was about 7, really nothing to write home about, looks pretty good. Then he exercises and the end diastolic pressure goes up to 24. I'll also say that angiograms were done, and I'm not going to show those today, but they showed that there are collaterals from the aorta to the bilateral subclavian arteries. So what do we take from all of this? Well, there's normal Fontan pressure in EDP, mild rise in Fontan pressure with arrhythmia, but significant rise in Fontan pressure and EDP with exercise. So now we have a new assessment, now that we have this new data. He has poor exercise capacity attributable to ventricular systolic and diastolic dysfunction. His EDP shot up when he exercised. And this sort of suggests to us that the etiology of the renal dysfunction is most likely cardiorenal. So what do we do with all of this? Well, there's no present need for structural intervention. I said the collaterals are collateralizing the arms. That's okay. We maximize the cardioprotective medical regimen, which Dr. Lurie talked about. Not great data, but we do it. He has a left ventricle, and that left ventricle doesn't work so well. We should certainly try. We also want to use pulmonary vasodilators on him if he's going to tolerate it, and you saw that he was on tadalafil earlier on. The other thing that you'll do in all your patients, of course, is to maintain euvolemia. So that's our summary of the hemodynamics. We're going to move on now to arrhythmia and thrombosis. So our list is a little bit smaller here, not going to take quite as long, but we do ambulatory rhythm monitoring as needed, and we have a very low threshold to perform an EP study. We also assess every patient for antiplatelet and anticoagulant therapy, which Dr. Lurie talked about before, very important in our Fontans. So our patient has a device, as I said, so he doesn't really need an ambulatory rhythm monitor. He needs an interrogation. And so here I've shown one representative image from his interrogation. And if you look at the middle panel on that image, you'll see his atrial tachyarrhythmia burden. Pretty much nothing for a really long time, and then all of a sudden you can see that histogram, the bar graphs sort of shoot up, and he had an increasing burden of atrial tachyarrhythmia. This is one representative image. Obviously, most of the time things are quiet, but when you see something like this, that causes alarm bells to go off. So now let's talk about thrombosis. What considerations do we have? Well, you heard earlier about the risk factors for thrombosis. I think it was Dr. Abelhosen that talked about that. The atrial pulmonary Fontan carries a higher risk of arrhythmia and thrombosis than other Fontan modifications, and this patient has an additional concern that we have to worry about. He requires full anticoagulation because he has a history of Fontan thrombosis and ongoing atrial tachyarrhythmias. He has pretty much all the risk factors. I have a representative transesophageal echo image on the left, and you know anytime an echo image has a giant red arrow in it, that should draw your eyes to an abnormality, and that abnormality here is this giant clot that he had before. So we sort of see this in our minds every time we see the patient, and we make sure that he's maximized on anticoagulation. So what's our assessment for arrhythmia and thrombosis? Well, he has an increasing burden of atrial tachyarrhythmia on his interrogation, and he has a really high risk of thrombosis. Not only did he have spontaneous echo contrast on his routine echo, but he has a history of a clot, and he has a history of atrial tachyarrhythmias, and he has an AP Fontan. So we keep him on full anticoagulation, and also we refer to EP study when we see that increasing arrhythmia burden with a plan for ablation of the atrial tachyarrhythmia, and there's one of his representative images in the bottom corner. So now we're going to move on to Fontan-associated liver disease. So here's our checklist. It involves laboratory screening, which Dr. Venick talked about. We screen for vaccinations, Hep B vaccination, hepatitis C screening for people who had their first surgeries early on. We do yearly liver ultrasound, we do cross-sectional imaging, and then when we do a catheterization, as Dr. Abelhosen talked about, we do a biopsy at the time of catheterization. So what data do we have for our patient? Well, he had platelets of 136. His GGT was 173. Dr. Venick talked about how that can be elevated in some of our patients with Fontan-associated liver disease. We also have a liver ultrasound that showed nodular coarsened echo texture, shear wave stiffness of F2 to F3, but importantly, patent vasculature, and also importantly, no masses. And the problem, as Dr. Venick talked about with interpreting studies like this, is that we really don't know the degree of fibrosis. Pretty much all the Fontan liver ultrasounds show some sort of coarsened echo texture. And I sort of end up glossing over that part because I've seen it so many times, but we sort of assume there's some degree of liver disease, but we just really don't know the degree of fibrosis. But it is important to note, because patients can get HCC, that there's no nodules, and it's important to know that the vessels are open as well. That's useful. So what's our assessment? Well, probably liver disease, and we don't know the severity of it. So we're going to monitor closely for signs of decompensation, like ascites or variceal bleeding. You heard that hepatic encephalopathy is rare, but you always keep your mind open if they have fatigue or confusion. We do a liver biopsy on an elective basis, usually with the catheterization, and then we refer to Dr. Venick to interpret all these things that we don't know how to interpret, or I don't know how to interpret. This leads us to our last piece, which is advanced care planning. So we readdress needs at each visit, short checklist. But a lot is happening here. These guys are being referred for procedures. They're getting tons of imaging every year. We're worrying about all these things. We're talking about the risk of long-term liver disease. We're talking about a whole lot of stuff, and it's important that we stop and go over the big picture with our patients. Does this patient understand his condition and his prognosis, or are we just ordering a bunch of tests? What are his immediate and long-term life goals? Does he have big life events coming up that we need to know about and that we need to include in our plans? Has transplant been mentioned, and in what context? Has anybody said, hey, a lot of people with your condition might get a transplant someday? Important to bring that up. God forbid he gets critically ill and is unable to communicate for himself. Has he appointed a surrogate decision maker? And have we talked about potential health states? Some people say, look, I had an aunt who was on hemodialysis long-term. I would never be on hemodialysis long-term. We got to know that. So that brings us to the whole survivorship protocol. I'm going to show you the full list now just to recap. We've gone over hemodynamics, surveillance, and optimization. We get yearly labs. We get a yearly echo. We get CPET every 3 years to monitor exercise capacity. We get advanced cardiac imaging at least once and then as needed. We do catheterization every 10 years, and we assess every patient for a phosphodiesterase inhibitor. Arrhythmias and thrombosis, we do ambulatory rhythm monitoring as needed. We have a very low threshold to refer for EP studies and ablations. We assess every patient for antiplatelet or anticoagulation. If there's no clear indication for anticoagulation, we want everybody on an aspirin at least. Fontan-associated liver disease, we do labs every year. We screen for hepatitis C. Have they ever been checked? Are they vaccinated for hepatitis B if they have chronic liver disease? We do a yearly liver ultrasound, looking mostly for nodules, vessel patency. cross-sectional liver imaging every 5 years. That usually means for us a liver MRI. Liver biopsy every 10 years with the catheterization. And the last part of our survivorship protocol is advanced care planning. Talk about big picture. That is it. Thank you.